Hope you are all in a sound health. Today our matter of discussion is acute coronary syndrome. So to define acute coronary syndrome, it is a conditions resulting from temporary or permanent occlusion of coronary arteries due to formation of a thrombus at the site of atheromatous plaque culminating in acute ischemia. So in the definition, dear students, there are two keywords. One is formation of thrombus and another is acute ischemia. So in short, formation of thrombus resulting in acute ischemia is acute coronary syndrome. And this is an spectrum.
Sorry, sir. একটু স্লাইড শো দিয়ে দেন স্যার। স্লাইডটা প্লেতে দিয়ে দেন স্যার। সরি স্যার। জি স্যার। Thank you.
Thank you. So this is a spectrum sharing a common initiation following plaque rupture or fissuring with platelet deposition and thrombus formation. Two major diseases are included in this ACS. One is non-ST-ACS, comprising of unstable angina and non-ST elevation myocardial infarction, and there is STE-ACS. In other words, it is STE-MI. As I already mentioned, this is a spectrum starting from unstable angina, then to non-ST elevation MI, then to ST elevation MI. It may start de novo or it may start with stable angina. So if you start with stable angina, it is atheromatous plaque, which is non-occlusive, and the condition of the atheromatous plaque is stable. But if the plaque fissuring or rupture occurs with superimposed thrombus formation, and if it is non-occlusive, and at the same time, if there is increased demand as well as decreased supply of oxygen, the stable angina patient will go to develop a condition called unstable angina. And these patients, if the thrombus at the site of atheromatous plaque become occlusive for the time being and it reopens, and during the time of occlusion, there will be some necrosis of muscle of the myocardium, resulting in non-ST elevated MI. And some of the patients with non-ST elevation MI, if the thrombus becomes occlusive for a long time, the muscle loss will be more, and the patient will develop ST elevation myocardial infarction. So these three conditions, unstable angina, non-ST elevated myocardial infarction, and ST elevated myocardial infarction, are three diseases included under the heading of acute coronary syndrome. So what is the importance of this diagnosis? Diagnosis by presentation, ECG and troponin eye estimation, as well as imaging, leads to the diagnosis of acute coronary syndrome. ECG should be done very quickly. It should be done as well as it should be interpreted within 10 minutes. So diagnosis of acute coronary syndrome is not very difficult, one. But differentiation of this condition, one ST elevation MI, another is non-ST elevation MI or unstable angina, is not very easy. It's sometimes very difficult. Diagnosis triggers both triage and management of the patient. So why diagnosis is important? Diagnosis is important because it is a dreadful disease. It has high mortality. So we have to diagnose the disease for proper management, sending the patient to proper places. And the level of management, it may be at community level, it may be in emergency room, it may be in cath lab, it may be in coronary care unit. Some of the patient has to be managed at the community level with some drugs. Some of the patient will be coming to emergency room. Also there, some management is given. Some of the patient should be brought to cath lab very quickly, and we have to do intervention and other things there. And finally, some of the patients will be going to coronary care unit at that particular time or after completion of the control of the condition in the cath lab. We are coming to that afterwards. Management immediately with antiplatelet and anticoagulant is needed. Consider, and all these patients are considered for immediate revascularization. It may be either mechanical revascularization or maybe pharmacological. if there is new ST elevation. In this ACS patients, if the ST elevation occurs, this patient needs immediate revascularization mechanically or pharmacologically. So the definition of myocardial infarction was first introduced by WHO in the year 1971, and it is still known by most of our colleagues, most of the medical personnel. That is presence of three cardinal features. One is chest pain, one is ECG changes, another is elevation of biomarkers. Among these three, if two is present, then diagnosis of myocardial infarction is done, and this is WHO criteria. But subsequently, there is universal definition given by some international authorities starting in the year 2017, and it was revised about 2 times, and final universal definition was proposed in the year 2012. So this universal definition suggests AMI diagnosis done when one of the following criteria is present in proper clinical settings. One is rise and or fall of troponin above 99 percentile of upper reference level, in addition to one of the following, such as ischemic symptoms, new ST elevation or UF changes, or new development of LVBP. Pathological cue, new regional wall motion abnormality on echocardiogram or other imaging techniques. Secondly, sudden cardiac death, often preceded by chest pain accompanied by new ST elevation or development of new left bundle block with intracoronary thrombus on coronary angiogram or autopsy, or a raised troponin I, provided blood was taken before death of the patient. Thirdly, PCI-related myocardial infarction, that is periprocedural increase in biomarker more than 5 times of upper reference level. Next is CABG-related myocardial infarction. Here also more than 5 times troponin I elevation accompanied by pathological Q or development of new LVBP, and graft or native artery occlusion on coronary angiogram or imaging evidence of regional wall motion abnormality. Finally, if there is pathological evidence of myocardial infarction, that is on autopsy, if someone do that like that. Now come to unstable angina. Unstable angina is a syndrome resulting from increased coronary arterial obstruction due to plaque rupture or thrombus formation. So this rupture of plaque as well as formation of thrombus is a common feature in all the three conditions under the heading of acute coronary syndrome. And in unstable angina also there is plaque rupture and formation of thrombus. So there are three principal types of presentation: descending angina, that is on the top of chronic stable angina, as already I have shown in the continuum of the conditions. Some of the patients of stable angina may develop unstable angina. So if angina severity increases, so it is unstable angina. Secondly, if the person develops rest pain or angina on minimal exertion, at least 20 minutes in duration. Thirdly, if there is new onset severe angina within 1 month of diagnosis. Now come to ST elevation myocardial infarction and non-ST elevation myocardial infarction. Acute coronary syndrome resulting from transient or permanently occlusive coronary thrombus leading to myocardial necrosis. So the difference of these two conditions from the previous one, that is unstable angina, is that here the thrombus is occlusive, at least for the time being. And in case of unstable angina, thrombus is not occlusive, it is partially occlusive. So as soon as there will be occlusive thrombus, some of the myocardium will be necrosed. And as soon as myocardium is necrosed, then the diagnosis becomes myocardial infarction. If there is partial necrosis, it is non-ST elevation myocardial infarction. And if it's through and through, that is transmural infarction, it is ST elevation myocardial infarction. And these two things are diagnosed on ECG. We are coming to that. Permanently occlusive will be ST elevation. Transiently occlusive, that is occlusion followed by reopening, will be non-ST elevation myocardial infarction. So, ST elevation migraine infarction, it is predominant form of ACS in Bangladesh. Incidence is increasing gradually. It occurs as on an average of 10 years earlier in Bangladesh compared to Western countries. Early revascularization via primary PCI or fibrinolysis decreases infarct size, preserves LV function, and improves survival. Primary PCI is considered to be the gold standard for revascularization. Thrombolysis is an excellent and realistic alternative in our country where primary PCI is not affordable by most of our patients. So we come to non-ST elevation migraine infarction. As you know, previously it was labeled as non-Q migraine infarction, but this terminology is no more existent because before development of Q in case of ST elevation migraine infarction by use of modern drugs and revascularization techniques, there is no further development of QF. So ST elevation MI is no more labeled as QF migraine infarction. In the same way, non-ST elevation MI are no more labeled as non-QMI. So the newer terminology is STMI and non-STMI. Now, regarding non-STMI, if we want to define, it is myocardial necrosis in non-transmural occurring without ECG evidence of ST elevation. As no ST elevation occurs, so it is not followed by development of Q. So it is non-QMI in the previous terminology. Ongoing chest pain without ST elevation on ECG are due to either unstable angina or non-STMI. So how to distinguish it is only by estimation of cardiac enzymes. If enzyme is elevated, it is non-STMI. If no elevation, it is not MI, rather it is unstable angina. So how to classify migraine infarction? Conventionally, migraine infarction was classified in various ways. Finally, there is a clinical classification which is universally accepted nowadays. But we are coming to that. Before that, let us see the classification of migraine infarction which is being used for many years in the literature. So, depending upon the extent of myocardium involved and corresponding ECG changes, it may be ST elevation migraine infarction and non-ST elevation migraine infarction. If we go to myocardium, what occurs in non-ST elevation migraine infarction? It is subendocardial infarction. In other words, in the previous terminology, it is non-Q migraine infarction. And in case of ST elevation migraine infarction, it is transmural migraine infarction. If we consider the location, as all of you know, it may be anterior MI, it may be lateral MI, it may be inferior, posterior, or combination. And sometimes right ventricle may be involved in migraine infarction. For all practical purpose, infarction means infarction of left ventricle because the muscle mass is 3 times more compared to right ventricle, and left ventricle bears the load of systemic circulation. So infarction means left ventricle infarction. And if the right ventricle is involved in some cases of inferior migraine infarction, we mention it separately as RB infarction. Depending on the size of infarct, it may be macroscopic or focal, it may be small, less than 10% of left ventricular muscle mass involved, it may be medium sized, 10 to 30% of muscle mass involvement of left ventricle, and it may be large when there will be more than 30% of the left ventricle involved. So this picture shows the left one is stable angina. Here there is atheromatous plaque and the endothelium is intact. So there is no endothelial erosion or rupture, and the flow is diminished, although not absent. In the left side, you'll be seeing that the endothelium is eroded, or there is rupture of the endothelium covering the atheromatous plaque, and there is deposition of thrombus. So the lumen is greatly narrowed, blood flow is reduced, and patient develops unstable angina. And if the thrombus is occlusive one, and occlusion followed by reopening, the patient will develop non-ST migraine infarction, and the occlusion, if persists for a long time, the patient will develop ST elevation migraine infarction. So this picture shows the location of infarction. The violet colored one is infarction, the yellowish colored one is ischemia. So the infarction starts subendocardially. It extends towards subepicardium with passage of time. After 4 hours, after 8 hours, the size of infarct increases. So at 1 hour, the subendocardium is infected, so it is subendocardial myocardial infarction. But the question is, why the subendocardium, all infection starts subendocardially? The reason is that as the muscle is contracting concentrically, at the left ventricle is contracting concentrically, so the tissue tension is maximum at the site of subendocardium. So that is the site where blood supply ceases for the first time during the process of infection. So infection starts at the subendocardium, it proceeds towards subepicardium, and in case of subendocardial myocardial infarction, that is non-elevated myocardial infarction, the infection confines to this particular area, and in case of non-ST elevation myocardial infarction, the infection extends subendocardium to the subepicardium. That means it becomes transmural. So if we do ECG, it is non-ST elevated myocardial infarction, and if we do the pathological examination, that is postmortem examination of the heart, it is subendocardial infarction. And if ECG shows ST elevation myocardial infarction, what happens in the heart? It is transmural myocardial infarction, like that. So this is a issue which is very important for the students in the examination. Most of the time, the question is asked: how will you differentiate non-ST elevation MI from ST elevation myocardial infarction? So if we consider some parameters, coronary occlusion is subtotal in case of ST elevation myocardial infarction. Actually, it is total for the time being, and following that total occlusion, it reopens. So afterwards, it becomes subtotal. But in case of non-ST elevation myocardial infarction, the occlusion is total. Extent of infection in case of non-ST elevation, it is subendocardial. Here it is transmural. Residual myocardium is more in case of non-ST elevation. Naturally, it is less in case of ST elevation. Early ischemia and reinfarction is more in case of non-ST. It is less because the geopartized myocardium is more with non-ST elevation myocardial infarction. If we do ECG will show in non-ST elevation MI ST depression or inversion, but there will be no T wave. Sometimes ECG may be even normal. Only troponin and other biomarkers are elevated. In case of ST elevation, ST will be definitely elevated, followed by there will be development of Q. Cardiac enzymes will be low in case of non-ST. It will be high because it depends on the extent of muscle loss. Thrombolytic therapy is not recommended in case of non-STMI. It is recommended in case of ST elevation MI. Heparin is class 2 indication, has class 2 indication in case of non-STMI. It is indicated in case of STMI only when we use tissue plasminogen activator, or sometimes patient develops presents very lately in that conditions. Heparin may be used in ST elevation MI. And finally, coronary angiogram and intervention is indicated more in case of ST elevated MI at presentation because there is more muscle, so there is scope of cell base of the muscle. And in case of ST elevated MI, it is also indicated as primary PCI, or it is indicated subsequently when there will be symptoms by the patient. And this is clinical or etiological classification now used in most of the places of the world. So it is suggested by the expert committee internationally. In this classification, as mentioned in the diagnostic criteria of myocardial infarction, they have not only suggested the diagnostic criteria, they also divided myocardial infarction into 5 classes. In type 1 is myocardial infarction as primary coronary event. There is PEC rupture and thrombus formation. In type 2, it is secondary ischemia from decreased oxygen supply or increased demand, and there is spasm or emboli into the coronary arteries, or if there is anemia, hypoxia, hypotension. In this COVID era, you'll be seeing that some of the patients are coming with features of acute coronary syndrome. And this particular condition it is said to be type 2 myocardial infarction because of hypertension, hypoxia, and other causes conditions increasing the oxygen demand of myocardium. Type 3 is in the setting of sudden cardiac death, may be preceded by ischemic symptoms accompanied by new ST elevation or new left bundle branch block or a fresh thrombus on coronary angiogram or autopsy. The patient dies and subsequently autopsy is done. Type 4 is it is associated with PCI, and in this particular type there are two subtypes. 4A means only in PCI, and 4B means if there is use of stent and stent undergo thrombosis with production of myocardial infarction. And type 5 is it is associated with CABG, surgery. Now, clinical features of acute coronary syndrome. These are more or less known to many of us, but still we want to do some recapitulation. So the symptoms are chest pain. It is severe, more than 30 minutes of duration, particularly in myocardial infarction. Nausea, vomiting, sweating, shortness of breath, especially in myocardial infarction, syncope, cardiogenic shock, left ventricular failure, sudden cardiac death. It may occur in any of the acute coronary syndrome subtypes. Signs: sympathetic activation resulting in sweating, tachycardia, restlessness, pallor, especially in case of anterior wall myocardial infarction, in case of ST elevation myocardial infarction. Vagal activation resulting in vomiting, bradycardia, especially in inferior wall ST elevated myocardial infarction. Impaired left ventricular function resulting in decreased pulse volume, increased JPP, low blood pressure. Heart sounds may be quiet in myocardial infarction. There may be development of third sound, murmur of myocardial mitral regurgitation or ventricular septal rupture may be developed in patients with ST elevation myocardial infarction. There may be pericardial rub in case of ST elevation myocardial infarction. Other features: fever, cold extremity, if there is cardiogenic shock, etc. So let us see the picture. This is very well-known picture in when we are student of third year. Is from McLeod clinical method. So this is a victim of myocardial infarction. So severe pain, and the pain is sometimes comparable with pain of delivery or something like that. But whatever may be the comparison, the chest pain, central chest pain, severe compressing type of chest pain, and the person who experiences this chest pain expresses his pain like that. He fisted hand is placed on the center of the chest, and it is like that of as if elephant, mad elephant is sitting on the chest. So the respiration will be going to be ceased, and there will be severe pain. So pain along with respiratory cessation, the feeling is something like that, very severe pain. So with this discussion, let us go to some sorts, something towards literature. I think among our students, there are some who read some literature books. In some literature books, some the description of myocardial infarction is very, very, very vividly given. এটা হচ্ছে আপনার ওই যে শীর্ষেন্দুর যে পার্থিব যে উপন্যাস, তাতে আছে যে বুক মথিত করা সেই ব্যথা, যেন এক মর্ত মাতঙ্গ পায়ের নিচে পিষে ফেলবে বুক। হার্ট অ্যাটাক, সারা পৃথিবী জুড়ে তার দাপট, বুড়ো বাচ্চা ধনী নির্ধন পাবলিক ভিআইপি সকলেই নত জানে তার কাছে। হার্ট অ্যাটাক এই দুটো শব্দ যেন দামামা বাজিয়ে দেয় বুকে। একটা স্পর্ধিত আভিজাত্য, একটা অমোঘ পরিণতির বিধান রয়েছে তাতে। অথচ কি সর্বনাশে, একটা হার্ট অ্যাটাক মানে কতজনের কত কি বন্ধ হয়ে পড়ে। হার্ট অ্যাটাক মানে হার্ট নিজে বন্ধ হয় না, হার্ট বন্ধ হওয়ার সাথে সাথে একটা ফ্যামিলি বন্ধ হয়। বিকজ heart disease, myocardial infarction occurs in the, mostly in the Middle East, especially in our country. So the incidence as well as the mortality of myocardial infarction is increasing throughout the whole world, especially in developing countries like Bangladesh. And this is a very good description of heart attack in literature. So again, let us come to our own subject. The differential diagnosis of acute coronary syndrome is like that. Non-acute coronary syndrome cardiovascular conditions. It is angina, pericarditis, aortic dissection, pulmonary embolism, stress, cardiomyopathy, Takotsubo cardiomyopathy. So these are non-ACS conditions, but cardiovascular, relating to cardiovascular system. And there are some non-cardiac chest pain coming into the differential diagnosis. There may be reflux, esophagitis, acute cholecystitis, acute pancreatitis, costochondritis, etc. And this thing also very important for exam for our students. Sometimes in the exam questions are asked, how will you differentiate the pain or of acute myocardial infarction from angina pectoris? In other words, how will you differentiate angina pectoris from myocardial infarction? If you consider pain, that angina pectoris pain occurs during exertion. In myocardial infarction, it is mostly in the morning. May occur in exertion, but most of the time it occurs in the morning. So with exertion, relation is more with angina, less with myocardial infarction. Duration, usually 5 to 15 minutes at a maximum in case of angina, but it is constant for 30 to 60 minutes in case of myocardial infarction. Precipitating factors, exertion, cold, exposure, anger in case of angina. There may not be any precipitating factors in case of myocardial infarction. Although in drama as well as in cinema, you'll be seeing that the actor is putting the hand and is getting myocardial infarction. But in a true sense, the precipitating factors are more in case of angina pectoris, but less in case of myocardial infarction. Relieving factors, rest and nitroglycerin provides relief in case of angina pain, but in myocardial infarction, no relief is offered by this rest or nitroglycerin. You have to use morphine, beta blockers, and sometimes completion of myocardial infarction gives relief. If there is no residual muscle after necrosis, there will be no pain. So automatically pain relieves, but at the cost of myocardium. So it's a grave condition, and the patient may develop some other complications like heart failure or cardiogenic shock. Association of angina pectoris is nil. In case of myocardial infarction, is vomiting, diaphoresis, dyspnea, etc. Another thing also important for exam for our students, I want to say, how will you differentiate acute myocardial infarction from acute pulmonary embolism? So it's very close. And in this COVID era also, some of the patients are developing possibly pulmonary embolism. So if we think of, consider risk factors in cases of pulmonary embolism, stasis, endothelial injury, hypercoagulable state, we call it burst-strike. So these three are precipitating factors, risk factors for acute pulmonary embolism. And in case of acute myocardial infarction, all of us know it is nothing but the risk factors of coronary artery disease, hypertension, hypercholesteremia, smoking, diabetes, etc. Symptoms in pulmonary embolism, chest pain, dyspnea, hemoptysis, faintness. In case of acute MI, chest pain, sweating, vomiting. Signs, cyanosis, raised JBP, hypotension. Second sound becomes loud, sometimes split in case of acute pulmonary embolism. In case of acute myocardial infarction, patient may develop hypotension. JBP may be raised. Heart sounds are soft because of necrosis, loss of muscles. If we do ECG, there will be no ST elevation in case of acute pulmonary embolism. Sometimes you may get S1, Q3, T3 pattern, or sometimes S1, S2, and S3 patterns. But in case of acute myocardial infarction, it is diagnostic. That means there will be ST elevation myocardial infarction followed by development of Q. Now, if you consider chest X-ray, in case of pulmonary embolism, it will be oligemic lung fields because of obstruction of pulmonary artery or its branches. There will be a vase or linear opacity because of pulmonary infarction. In case of acute myocardial infarction, chest X-ray is most of the time normal. If there is development of heart failure, features of pulmonary edema may be present. If LV involvement necrosis is more than 30% or like that. If we do cardiac enzymes, it is normal in case of pulmonary embolism. Most of the time, it is raised in case of acute myocardial infarction. D dimer is positive in case of embolism. It is negative in AMI. Coronary angiogram, if done, it gives positive results. That is occluded coronary arteries in case of acute pulmonary embolism. It is coronary angiogram. Sorry, it will be positive in case of acute myocardial infarction. It will be negative in case of acute pulmonary embolism. And if we do HRCT, it is now frequently done in suspected COVID patients. It will be positive in case of acute pulmonary embolism. It will be negative in case of acute myocardial infarction. Heparin use always indicated in acute pulmonary embolism. It is sometimes indicated, not always, sometimes indicated in case of acute myocardial infarction. Thrombolytic therapies sometimes are used in case of acute pulmonary embolism in form of tenecteplase. It is always used in case of acute myocardial infarction if not contraindicated otherwise, and the patient presents within 12 hours. Another important thing is how to differentiate acute myocardial infarction from aortic dissection. Also important for our students for examination purpose. If we consider risk factors, acute dissection risk factor is hypertension. Sometimes connected to disease like Marfan syndrome. In case of myocardial infarction, again risk factors are coronary artery disease risk factors. Pain, in case of aortic dissection, it is tearing, severe pain, maximum at onset. Very characteristic feature is pain is maximum at the beginning of tear. That means at the onset, pain is maximum, and it radiates between two scapula, interscapular radiation. In case of myocardial infarction, it is compressing pain, as already mentioned, increased in severity with passage of time, not maximum at the start, like that, unlike that of aortic dissection. Cardiac enzymes is normal in aortic dissection. It is elevated in myocardial infarction. Beta blockers may prevent aortic dissection. But in myocardial infarction, it is used, especially patient develops anterior myocardial infarction. But in case of aortic dissection, beta blocker is a must to prevent further dissection. Intravenous nitroprusside used in all of the patients with aortic dissection. It is occasionally used if the patient is hypertensive or some other coexisting conditions are there in case of acute myocardial infarction. Thrombolytic therapy is rather contraindicated in case of aortic dissection. It is indicated, very much indicated in case of acute myocardial infarction. It is to be noted that some of the myocardial infarction patients develop aortic dissection. In other words, some of the aortic dissection patients may develop acute myocardial infarction. If the dissection proceeds proximally towards aortic cusp, that is aortic sinus, the coronary arteries may be involved, and there may be development of myocardial infarction. Some of the patients, and this is the only condition where myocardial infarction itself is a contraindication in use of thrombolytic therapy. Myocardial infarction resulting from aortic dissection contraindicates thrombolytic therapy because there will be more dissection if we use thrombolytic therapy. Surgery in proximal type of aortic dissection, surgery is the treatment. And in case of myocardial infarction, sometimes if there is complications like ventricular septal rupture, myocardial regurgitation, or cardiac rupture, CABG is undertaken. So we consider the complications: arrhythmias, PVC, ventricular tachycardia, ventricular fibrillation, atrial fibrillation, sinus bradycardia, heart block may be present as electrical complications, arrhythmic complications. And if we consider mechanical complications of infarction, there may be left ventricular failure, or if it is of more severe degree, patient may develop cardiogenic shock. Pericarditis in third or fourth day if there is estimation myocardial infarction. Mechanical complications like papillary muscle rupture, ventricular septal defect, mitral regurgitation, cardiac rupture may occur. Sometimes there may be embolism, and in late complication there may be left ventricular aneurysm in anterior myocardial infarction. So this picture shows development of infarct expansion. The person having anterior wall myocardial infarction, the left ventricular apex is pulsed, and there is stretching of the myocardium, infarcted muscle with adjacent muscle undergoing hypertrophy. So this is a change of model of the heart. the heart is conical in shape, as all of you know it. But here the heart has become somewhat like that of hourglass. So this is remodeling. The model of the heart is changed. The original model is no more existent. So the heart is remodeled, and the person is going to develop heart failure and other complications. So our aim will be to prevent this remodeling, and the drug which are used to prevent this remodeling is SC inhibitor and beta blockers. This echocardiogram shows there is a mosaic jet flowing from left ventricle to right ventricle, as you are seeing from left ventricle to right ventricle. So this is a case of ventricular septal rupture developing in patients with acute anterior myocardial infarction. So it's a mechanical complication. So how to investigate? So it starts with ECG. ECG shows ST elevation, progressive loss of R wave, and this ST elevation will be followed by development of Q and T inversion. Ultimately, in old infarction cases, there will be only presence of pathological Q, and all other features will be normalized. Cardiac enzymes, there will be raised troponin, and if CKMB is done, it will be also raised, but more sensitive is troponin I. Echocardiogram, chest X-ray, evaluation of coronary heart disease risk factors, and coronary angiogram if primary PCI is planned or if pharmacoinvasive strategy is planned. Treatment: morphine, persistent pain, anxiety, pulmonary edema. So morphine is the drug of choice if the patient comes with severe chest pain. So the pain is so severe that morphine and other narcotic analgesics are often needed to stop the pain. Besides relief of pain, morphine has beneficial effect in control of pulmonary edema. Also, it relieves anxiety. Anti-ischemic drugs: nitrate, beta blocker, calcium channel blocker. Antiplatelets: aspirin, clopidogrel, GP2B3 in high risk patients. Anti-thrombotic like heparin, a class 1 indication in case of unstable angina, class 2 indication in case of non-ST myocardial infarction. Primary PCI is more and more undertaken as a control of as a measure of revascularization worldwide. Although in our place we cannot go for primary PCI, we are going for primary PCI in some of the selective patients, but throughout the whole world, this is the gold standard for revascularization technique in a patient presenting with acute coronary syndrome, in other words, ST myocardial infarction. Thrombolytic therapy is the alternative for our patients in presenting with ST myocardial infarction, and we are practicing in our place and many other developing and underdeveloped places of the world. Lipid-lowering agents, aggressive statin therapy is mandatory for these patients. SC inhibitor to prevent remodeling, as already mentioned, in case of anterior wall myocardial infarction, or in other infections like interior infections if ejection fraction is less than 40%. Intervention: primary PCI, and if the person is refractory, having refractory angina, intra-aortic balloon counterpulsation may be undertaken as an interventional treatment. Finally, coronary artery bypass surgery, especially if the person is diabetic, if the ejection fraction is low, and it's actually not in the acute setting. In acute setting only if there is mechanical complications. In long-term treatment of patients of acute myocardial infarction after getting angiogram, if angiogram reveals triple vessel disease or left main stem disease, or mechanical complications like metabolic agitation, ventricular septal rupture is there, coronary bypass surgery is undertaken. Thrombolytic therapy in ST myocardial infarction, it is generally preferred in patients who are not in shock. If the person is in shock, thrombolytic therapy is not going to do any good to the patient. No contraindication to thrombolytic therapy. Who have no invasive option, that is cath lab unavailable. Delay in performing PCI, that is door to balloon time minus door to needle time, if exceeds 1 hour. So it is better to give thrombolytic therapy. But as I already mentioned, the gold standard in reverse flow therapy throughout the whole world is primary PCI. Thrombolytic therapy contraindication, most of us know, but still for completion we are mentioning it. Absolute contraindication is prior intracranial hemorrhage, ischemic stroke within 3 months, known cerebral arterial malformation or malignancy, aortic dissection, head injury in last 3 months, and active bleeding if present. Other contraindications, relative contraindications are blood pressure more than 180 by 120, ischemic stroke more than 3 months back, prolonged traumatic CPR, recent internal bleeding within 2 to 4 weeks, active peptic ulcer disease, others sometimes non-compressible puncture site, warfarin use, pregnancy, exposure, recent exposure to streptokinase because of allergy of that drug or antibody produced by streptokinase. Now, the important thing is PCI in ACS indications. Some is also a paid question by most of the examiners and is practiced throughout the whole world. Is a standard treatment for patients with ACS. So, in case of unstable angina, non-activated myocardial infarction, it is done in high risk patients, not in low risk patients. So, who are high risk patients? They are those who have prolonged pain for more than 20 minutes, dynamic ST changes more than 1 millimeter, presence of S3 gallop, new mitral regurgitation, pulmonary edema, severe left ventricular dysfunction. If there is electrical instability, if there is raised cardiac biomarker, if there is prior PCI, CABG in patients presenting now with unstable angina or non-STEMI in last 6 months. In case of activated myocardial infarction, primary PCI, the gold standard already mentioned. It is the reperfusion therapy of choice. But here, door to balloon time should be within 90 minutes. Patient should not be, and the patient who are not allergic for fibrinolysis, high risk for stroke, patient who are not eligible for fibrinolysis, where there is high risk of stroke, especially in elderly patients, and those who are in cardiogenic shock. So these subsets of patients importantly now practiced more and more in various places of the world, including our country, is pharmacoinvasive therapy. It is a reasonable alternative to PCI, where PCI is not affordable, not being undertaken because of some limitations. These pharmacoinvasive therapy are a reasonable alternative. Also, delayed or secondary PCI in patients with post-MI pain, congestive heart failure, sustained BT, positive pre-discharge stress testing. Now come to primary PCI. PCI has revolutionized the care of ACS. 80% of PCI done in ACS patients in USA. Only 20% of PCI are done now for patients with chronic stable angina in USA. So 80% of the PCI are being done as primary PCI in patients with acute coronary syndrome and others. Initially introduced as an alternative to fibrinolytic therapy in activated myocardial infarction, now recognized as the reperfusion therapy of choice. Current guidelines recommend primary PCI as the default reperfusion strategy for patients with activated myocardial infarction. It restores coronary flow promptly in 90% of the cases. The percentage is much more higher than thrombolytic therapy. Superior to thrombolytic therapy in reducing death, reinfarction, intracranial bleeding, reocclusion of infarct-related artery, and recurrent ischemia. Now come to PI, that means pharmacoinvasive strategy. Timely thrombolysis followed by PCI is a reasonable alternative to primary PCI in STEMI. Here, in pharmacoinvasive strategy, PCI is a mandatory one after having thrombolytic therapy. But in case of rescue PTCA, the PCI is done in patients who are having symptoms where PCA, the thrombolytic therapy is not successful. So is the difference. Tenecteplase given in a bolus, fibrin specific. This tenecteplase is fibrin specific with minimal depletion of fibrinogen in the circulation. Tenecteplase administered early, followed by PCI within 3 to 24 hours. So after administration of this tenecteplase, within 3 to 24 hours, not before 3 hours, but between 3 and 24 hours, primary PCI is undertaken. It's not primary PCI. So as it is done after thrombolytic therapy, so pharmacological thrombolysis, so it is pharmacoinvasive strategy. Current data support the strategy of early routine PCI after fibrinolysis rather than a conservative approach of fibrinolytic therapy only. Already mentioned. There is a trial STREM, a stream trial provided that strategy involving early fibrinolysis with bolus tenecteplase and adjunctive pharmacotherapy followed by PCI offers similar efficacy to that of primary PCI in patients with ST-level infection who presented within 3 hours of symptoms onset and who cannot undergo primary PCI within 1 hour. So the outcome result is comparable to primary PCI in case of pharmacoinvasive therapy, as evident from STREAM trial. Pharmacoinvasive strategy is safe with low thrombus burden, better TME3 flow at time of procedure. So this picture shows there is an occlusion in the right coronary artery as indicated by 2 arrows, and there is a thrombus and the filling defect actually in the right coronary artery in the middle of the second part of the right coronary artery after the right ventricular branch. And after doing this primary PCI, you are seeing that in the lower picture, the caliber of the right coronary artery is clearly visualized. The thrombus is gone and the distal flow is more or less almost normal. So good TME3 flow. So this is also important for examination purpose for our students, how to differentiate primary PCI from thrombolytic therapy. So its indication is, in case of primary PCI is STEMI as well as non-ST-elevated myocardial infarction. Thrombolytic therapy only in STEMI. In case of non-STEMI, you cannot use thrombolysis. Benefit confined to first 12 hours in case of thrombolytic therapy, because there is no recommendation of use of this thrombolytic therapy after 12 hours in case of ST-elevated myocardial, because the muscle, the residual muscles are not significant. Remaining muscles are very minimal after 12 hours. So after 12 hours, there is of no use. But in PCI, it is beneficial even after 12 hours. The perfusion therapy is more complete in case of primary PCI, is it is less complete in case of thrombolytic therapy. Bleeding risk is less only at puncture site, but bleeding risk is more in case of thrombolytic therapy, and the most dangerous one is intracranial hemorrhage. Early reocclusion is less in primary PCI, is more in case of thrombolytic. In cardiogenic shock, beneficial one is primary PCI, but in case of the thrombolytic therapy is is of no use. Benefit is doubtful. Mortality benefit is more with PCI, is less with thrombolysis. So we have come to our end, dear audience. Unstable angina, non-ST-elevated myocardial infarction, ST-elevated myocardial infarction share similar pathophysiological characteristics, but differing clinical severity. Accurate diagnosis and grading of severity needed to assess the risk and benefit of therapies. Medical therapy may be sufficient for majority of the patients with unstable angina. Non-ST-elevated myocardial infarction may require more urgent mechanical revascularization intensive antiplatelet and antithrombotic therapy. ST-elevated myocardial infarction require emergent revascularization in addition to aggressive secondary treatment of in addition to aggressive medical therapy. Secondary treatment of coronary heart disease with statin, beta blockers, ACE inhibitors should be continued for a long time and possibly lifelong. Primary PCI is the dominant revascularization strategy in STEMI. Pharmacoinvasive strategy is a reasonable alternative of primary PCI in ST-elevated myocardial infarction. So, thank you for patient hearing.
So, thank you, Prabir sir, for your very elaborate, nice, and well-structured lecture. It's actually a huge lecture. It usually covers by 2 or 3 lectures, but you, in a timely fashion, you covered very nicely and excellently in one lecture all the important things together. Sir, can you just stop sharing so that we can... So today is a very important topic today is discussed. Acute coronary syndrome, which comprises acute ST elevation AMI, non-STEMI, and unstable angina. This is not for only exam purpose, but also for day-to-day practical life. And also this is very important, sir, also very nicely elaborate today the pathophysiology and mechanism. And also this COVID era, there are so many ST elevation and non-ST elevation mimickers may arise and may create confusion in the management. So I think there are a lot of questions in the chat box. We will discuss those things, and we have among us two distinguished guests, Professor Mustafa Kamal sir and Professor Ujjwal sir. We welcome, and we will also have heard before our end their valuable comments. So do you have any question? If you have any question, you can put in the chat box, and also you can raise your hand and you can ask directly. So there is one question. A patient is acute MI. Is acute MI with cardiogenic shock. Which analgesic we should use? Morphine or pathogen? Professor.
Actually, already, as I already mentioned, drug of choice is actually morphine. Acute cardiogenic shock means patient is in heart failure. If the heart failure is of severe degree, then patient develops cardiogenic shock. So shock and cardiogenic shock and left ventricular failure is the difference is only in severity. Is basically two same things. So drug of choice is morphine, as mentioned. Left ventricular failure, drug of choice is morphine. So also in case of cardiogenic shock, drug of choice, provided patient is anxious, patient is having chest pain, but in absence of any severe degree chest pain, or if the patient is not anxious one, use of morphine is not mandatory. Rather, the hemodynamic support with the drugs used for cardiogenic shock should be undertaken. So, if at all analgesia is needed, the drug is morphine.
There is one more question about morphine. If patient's SpO2 less than 90%, can we continue morphine?
SpO2 less than 90%. As what the risk of morphine is, it produces respiratory depression. So less than 90%, possibly, to my opinion, morphine should not be actually used, because the thing is, if we use morphine, respiratory depression may occur, and the more important thing is the antidote which is needed to revert the action of morphine. If not at hand, morphine should not be used. In this particular condition, as the SpO2 is less than 90, it is better not to use morphine.
Okay, there is another question that I think you already mentioned in the lecture. Why subendocardium first involved in ischemia or MI?
Already mentioned, but for more emphasis, I'm mentioning the subendocardium is area which bears the brunt of the compressing force of left ventricle. Just think of left ventricle. If the left ventricle contracts from all around, the maximum contractile force falls on subendocardium. So because of increased tissue tension, the capillaries which are supplying in this particular area are being compressed at a maximum to the maximum extent, and so to the cause where blood supply to the subendocardium ceases first. Although there is blood adjacent to the subendocardium in the cavity of the left ventricle, and there is chance of some diffusion of this blood contained in the left ventricular cavity, but even because even in spite of that, the blood supply to the endocardium ceases first, subendocardium ceases first because of contractile force of left ventricle, increased tissue tension. So all infection are subendocardial to start with, whether it is subendocardial at the last or it becomes transmural.
There is another question. We do not do primary PCI after fibrinolysis. When is the suitable time for CAG?
If we plan pharmacoinvasive therapy, the after giving thrombolytic therapy, the time of undertaking this PCI is between 3 to 24 hours. So we have to do angiogram CAG between these periods, starting from 3 hours after giving thrombolysis. We can do it up to 24 hours. So this is the time.
Okay, sir. Can I just add in this point one more?
Okay.
So after thrombolysis, we have to actually check after 90 minutes or within 2 hours the effect of thrombolysis is sufficient or not. So we can check by whether there is 50% fall of ST elevation, symptom resolve, all these things. If it is not happen, then the question as a rescue PCI that can be done by 3 to within 24 hours, which may be even extended up to 48 hours. Beyond that 48 hours, it is clear no. That means then we'll do after discharge of the patient, when patient will again ideally by suboptimal ETT or symptom driven, we can do the CAG.
Yes, Thank you. So for pharmacoinvasive, this is 3 to 24 hours. For rescue and delayed PCI, this as Dr. has mentioned. Okay.
I think all question addressed. Somebody is wanting the soft copy of the lecture.
Oh, it may be supplied. Renata Pharmaceuticals doing the arrangement.
Okay. Okay, sir. I think the question is
just assure him that it will be supplied. The company who are providing us the technical support, they'll be providing. They assured me they'll be doing it.
Yeah, they will keep it in their. There is a group, Doctors Hub. There will be the lecture will be in recorded form, so you can have this from there. So today's lecture is not only important in the written. This is there may be case scenario like this. Patient comes with less than 24 hours chest pain with shock. How you proceed? Then you have to discuss all the things, all the options like primary PCI, pharmacoinvasive, and if not at all is possible, then what other options? Indication, contraindication of the thrombolytics. All this you may have to discuss in your written. And the question, all this are very nice to describe about the different types of MI, universal and as well as the physiology, etiological classification. These are frequently asked in the exam. And also the time is very important. This is very frequently, and this is considered as a basic. When you will do ECG within less than 10 minutes. When you do the thrombolytics within 10 minutes. And when you do the primary PCI, if you have the road to needle times are rightly mentioned 90 minutes, or you can extend up to 2 hours. That means 120 minutes. Or if you do not have in the PCI capable center, you can transfer the patient within 90 minutes to a PCI capable center. All these times you have to keep in mind. So we have two distinguished guests among us, Professor Mustafa Kamal sir. So can you have your brief comments, sir, about today's lecture? Mustafa Kamal sir.
Thanks to Dr. Anish Actually, thanks to Professor Prabir Kumar Das for this excellent deliberation. Yeah, in a very short time, yes, elaborately he has told about this management and this impression about acute coronary syndrome. Today, with a heavy heart, I like to express great sorrows at the death, sad demise of Professor Abulhosen Kamsudri, who was a former director of an ICBD and a great international cardiologist. We are very sorry. A lot of doctors has already expired due to this COVID infection, and we are in COVID era. So we'll have to manage excellently by keeping ourselves safe. দেখেন আমি পোস্ট গ্রাজুয়েট স্টুডেন্টদের জন্য এটাই বলতে পারি যে আপনাদেরকে বেশি বেশি করে অ্যাকিউট করোনারি সিনড্রোমের পেশেন্ট দেখতে হবে। একটা পেশেন্ট থেকে আরেকটা পেশেন্ট অনেক ডিফারেন্স। আমার কথা শোনা যাচ্ছে?
হ্যাঁ শোনা যাচ্ছে স্যার।
হ্যাঁ, একটা পেশেন্ট থেকে আরেকটা পেশেন্ট ডিফারেন্ট হয়। একটা রোগীর প্রেজেন্টেশন থেকে আরেকটা রোগীর প্রেজেন্টেশন ডিফারেন্ট হয়। একাডেমিক যা বলা হয়েছে এই বেস নিয়ে আপনারা বেশি বেশি করে রোগী দেখবেন। তবে খেয়াল রাখবেন কোভিড এরাতে কতগুলি প্রবলেম হচ্ছে যে এসটি এলিভেশন নিয়ে অনেক সময় এসটি এলিভেশন সময় খুব কেয়ারফুলি দেখবেন কোন পেরিকার্ডাইটিসের পেশেন্ট আসলো কিনা, কোন মায়োকার্ডাইটিসের এই যে মায়োকার্ডাইটিসের পেশেন্ট আসতেছে কোভিড এরাতে, এইটাতে এই এসটি এলিভেশনের ডিফারেন্সটা একটু ভালো করে দেখবেন। আর বর্তমানে তো বলা হচ্ছে যে কোভিড এড়াতেই আমরা থ্রম্বোলাইটিক দিয়ে চিকিৎসা করবো, as long as আমরা খুব ব্যাডলি যদি নেসেসারি না হয় পিসিআই, আমরা থ্রম্বোলাইটিক দিয়ে চেষ্টা করবো। আর থ্রম্বোলাইটিকের মধ্যে আপনারা তো জানেন যে প্রেফারেবল, এটা প্রেফারেবল। তো আমার মনে হয় থ্যাংকস, আমার আর বেশি বলার কিছু নেই। আমি স্পিচটা খুবই ভালো হয়েছে। আপনারা সবাই প্রত্যেকদিন বেশি বেশি করে রুগী দেখবেন, প্রত্যেকটা রুগী আমাদেরকে অনেক কিছু শেখায়। থ্যাংক ইউ।
থ্যাংক ইউ কামাল স্যার। And may I now request Professor Ujjwal sir, please, to have brief comment. Ujjwal sir.
Okay. And I must thank Professor Prabir for his beautiful lecture. That will be very helpful for our students. This lecture is very elaborate. I am not a cardiologist, but in this COVID era, I have gone through many papers, that is articles, relating to COVID and cardiac disease. And all of us know that COVID is characterized by coagulopathy. That is, extensive thrombosis is predominant in almost all arteries, coronary artery, pulmonary blood vessels, cerebral artery, everywhere. So, and in some papers I have seen that many patients died due to cardiac complications. So, in our institution, that is in Chittagong Medical College, how these cardiac patients, cardiac complications are addressed, whether they are addressed accurately or not, that is perfectly or not, because COVID-related myocardial infarction is one of the important presentation. If we can address this, we can save many lives. So mortality will be reduced. This is written in many articles and recently published in journals. So this is one question. In my experience, few days ago, one of my very close relative went to market in the morning, and while he is coming on walking, suddenly he fell to the ground. He was diabetic and had a history of stenting 3 years ago. So for our students, how this patient this type of presentation can be addressed or can be identified, and that is important for our students. And that is, I want to mean silent MI, how presents. Silent MI, how presents. We should not ignore this. So any symptom And my experience is that once upon a time when I was consultant, I found one patient just presented with confusional state, acute confusional, no history of chest pain. And on the next day when I have done ECG, and it was clear acute anterior MI. So acute confusional state is another presentation silent MI. So there are some other things important. Another question is, can acute MI occur in reproductive age or in pregnancy? I don't know. Professor Prabir, have you any idea?
It's uncommon but not rare. May occur. Especially if the mother is diabetic one.
Oh, okay.
Pregnancy is a hypercoagulable state. So
Yes,
although
that
there
is
is some protection by the pregnancy hormones in the reproductive age, estrogen especially, but the benefit provided by the protection provided by the estrogen is neutralized by presence of diabetes. The person, if the mother is diabetic, and the risk is still remains for development of migraine infarction. The uncommon.
uncommon. I experienced one. I faced one patient after delivery. She developed severe chest pain. After one day, she developed young. She's around 25 or 30, like this. Young woman developed severe chest pain and breathlessness. And I thought initially it was a case of peripartum cardiomyopathy. I faced many peripartum cardiomyopathy during my consultant duration.
No.
But
ECG
after
revealed
that,
migraine
no,
infarction.
I am completing. I am not finished. Later, when I have done ECG, it showed clear-cut acute myocardial infarction. That is elevation in the anterior chest leads. Still, I can remember it. And when I have gone through the literature, and there is written that coronary artery dissection is one of the important cause of acute myocardial infarction in pregnancy or during delivery. And that attracted me, and still I can remember the patient. So during post-graduation, actually, specialists know everything in details. So these are the few things, especially during COVID era. How are you dealing with cardiac patients, especially cardiac infarctions? As many patients, my patients present with hemiplegia, that is a stroke, COVID patient. My patient, COVID patient, present with myocardial infarction. So, and in literature, that is in papers, they published in current journals, that many patients are with coronary artery thrombosis. So, how are you dealing with these patients? So, this is one. Anyway, I am completing my speech. I think this is very useful. This is very useful because this is the leading cause of death worldwide. In this current era, and cardiology is one of my favorite subject in internal medicine. The other subjects are very complicated, but if we have a very clear idea, anatomy, physiology, and clinical experience, cardiology diagnosis is very easy. Only clinical history bedside and ECG, X-ray, and an echo is sufficient to diagnose more than 95% of the cardiac patients. So this is a very easy subject, but life-threatening. We must deal with urgently. We must deal with it. So this should be kept in mind. I am especially talking to our students. So this is very important. The diagnosis is very easy, and treatment is also available. Very effective treatment. for example, you are telling about primary PCI, very important. All over the world, it's going now, and other treatments are also as well is a present. And now people are being aware with modifiable risk factors, and they are doing well. So in some countries, especially developed countries, the rate of cardiac coronary artery disease is declining. That is another point. So anyway, this is a very elaborate lecture. This was it, and you have covered all these things, and our students, I think, will be benefited very much benefited. Will be very much benefited. So thank you all.
Thank you, sir. We are almost at the end of our program. Before end, I just like to highlight one of the points. You are using different antiplatelets with different their potential, but one have to remember prasugrel should only be used if the patient is going to be do the PCI. Only on those patients you load the patient with the prasugrel. Otherwise, you pay with the aspirin and clopidogrel is good enough. Nowadays, you have better option ticagrelor, but the option cost is the issue. But whatever antiplatelet you choose, any ACS patient, these have to be continued for a year. Dual antiplatelet needs to be continued for a year unless it is contraindicated by other issues like bleeding or something else. So before end, I like to ask again, Professor.
রানাটা কিছু বলবে? রানাটার অফিসিয়াল কেউ কিছু বলতে যাচ্ছেন? বলে নাই না?
যদি অ্যালাউ করেন স্যার তাহলে প্রতিদিন।
হ্যাঁ, একটু সংক্ষেপে কিছু বলতে চাইলে বলেন, তারপর আমি বলে শেষ করবো আর কি।
জি স্যার, শিওর স্যার। তাহলে 3 মিনিট সময় নিচ্ছি স্যার, উইথ কাইন্ড পারমিশন। Honorable Speaker, Honorable all attendee doctors and panel experts, Assalamu alaikum. This is Ishtiaq from Limited. I will not take much time. Today's discussion was based on acute coronary syndrome. We'd like to present some drugs on in the treatment of chronic coronary syndrome or chronic angina. As per European Society of Cardiology, in the treatment of stepwise chronic coronary syndrome, beta blockers are highly preferred because it controls the heart rate and keeps the patient safe. Beta blockers are thought as by European Society of Cardiology to reduce the mortality rate and chance of heart attack. It is also thought to be very effective in symptomatic treatment of classical angina. It is also useful to keep the heart rate within 55 to 60 beats per minute. We have selective beta 1 receptor blocker, bisoren, in 2.5 and 5 milligram, and which is produced from the certification of European grade raw material. Besides that, we also have statins. Statins are highly recommended to prevent the cardiac events like heart attack. And rosuvastatin and atorvastatin are mostly recommended by European Society of Cardiology. We have rosuvastatin 5 and 10 milligram Rolip, which is very effective in controlling triglyceride and LDL, has a high viability and a significant reduction of cardiovascular risk. It is also manufactured from certification of European grade raw material. We also have atorvastatin 10, 20, and 40 milligram tablet, which is available in the updated isomeric form of atorvastatin, 3R fiber, which is less in side effects, more in action. Besides that, we have antiplatelet drugs, which is recommended by European Society of Cardiology as dual antiplatelet therapy, aspirin, clopidogrel. We have that as Plagrin plus, and we also have for maintenance therapy, Plagrin, the plain clopidogrel. And we have anti-anginal drugs like trimetazidine in the name of Trizodone MR, which is twice daily dose and very effective in reducing the number of angina attacks and duration of angina. And it is manufactured as per the updated British Pharmacopoeia. And beside that, nowadays, as per American guideline, many doctors are using ranolazine for the treatment of chronic angina. We have Antogenier, which is ranolazine, approved by European Society of Cardiology and American Heart Association. And it has additional effect that it also helps to control diabetes, not as an anti-diabetic, but partially helps to control the diabetes or glycemic index. That's all from me. Thanks to the Honorable Speaker, Honorable Coordinator, and all attendee doctors. Thank you.
Professor, sir, for your final comment, sir.
Next, have you declared the next class?
Next class, sir, will be taken by Associate Professor Dr. Ashish Dey. He will talk on PCI.
In the same time, Saturday, coming Saturday. Okay. So thank you all, learned participants, senior participants, Professor Syed Mustafa Kamal, Professor Ujjwal Kanti Das, moderator Dr. Anis, our students, the officials of Renata. So, as mentioned by Professor Mustafa Kamal, also we express our deep condolence for our teacher, Professor Abul Hussain Khan Chaudhary. He was ex-director of NICBT. He just died today. Also, we express our condolence to wife of Dr. Moijul. Dr. Moijul Akbar Chaudhary is also cardiologist. He is the alumnus of our department. He did his MD from our department. He lost his wife a few days back. We are deeply shocked at the death of our cardiologists as well as our all doctors. We pray to God for their eternal peace, and we thank our participants for their cordial participation, active participation. We will try to continue our effort in the next few weeks and try to complete our subject with a couple of lectures. So thank you all. Thanks, Renata, for conducting this.
Thank you.
Thank you, sir.